Hello and welcome everyone. This is our part 2 of rapid fire pharmacology review of antimicrobials for the USMLE Step examination. And if you like this content, please like, share, subscribe and follow for more. And in this video, we are going to continue with the antimicrobials review. And by the end, once you master the antimicrobials, you will be able to answer the antimicrobial questions on your step examination with a score of greater than 80%. So let's do a quick review and recap of what we did in the part 1, and then we'll just cover up with the part 2, right? So first thing first, we did the mechanism of action for penicillin, cephalosporins, that they bind basically to the transpeptidases or the penicillin binding proteins. They basically have a beta-lactam ring, GLR analog. They inhibit the bacterial cell wall synthesis and they inhibit the cross-linking of the peptidoglycans GLR. Then another very important thing, we went through the mechanisms of resistance. How does a bacteria that's sensitive to penicillin becomes resistant to penicillin but still sensitive to methicillin? So sensitive to penicillin to MSSA, that is resistant to penicillin by beta-lactamase production. Then the next step was from a bacteria that is sensitive to methicillin to resistant to methicillin, so MSSA into MRSA by altered PBPs. And the third step was MRSA, that is resistant to methicillin but sensitive to Vanco and now becoming vancomycin resistant by converting the DLR subunits to DLR-DLAC. So this was something very important. And then we went through that 90% of the community acquired staph infections are basically MSSA. Therefore, the three options that we have for treating these infections were, we are all either going to use dicloxacillin, which is a methicillin class antibiotic, or we will use cephalosporins such as cephalexin, or we will combine a beta-lactamase inhibitor such as amoxicillin clavulanate, right? And then we quickly covered that, of course, the beta-lactams are so efficacious that if the patient has a history of anaphylaxis to penicillin and the patient has syphilis, we are still going to desensitize and use penicillin. And we discussed that if the patient who has endocarditis and was started on Vanco, and now we come to know that the patient is MSSA, we are still going to DC and discontinue Vanco and start neficillin, because neficillin trumps Vanco in case of MSSA, but for MRSA, Vanco wins over methicillin class antibiotics. And similarly for syphilis, even if the patient has history of anaphylaxis, penicillin still wins. And then we said that penicillins and aminoglycosides are partners in crime, therefore penicillins just break down the cell wall and aminoglycosides can go inside and break down the protein synthesis. And then we did the high yield allergies, that if there's a rash, history of rash to beta-lactams, yes, we can still use cephalosporins. If there's a history of anaphylaxis, no, we cannot use cephalosporins. And if the patient who was recently started on an antibiotic, we did these two scenarios. A patient recently started on an antibiotic and now has rash and EOs in the urine and EOs in the blood, then the diagnosis is AIN, and the drugs that we are going to keep at the back of our mind are NSAIDs. Of course, if the patient was not on antibiotics, this was our mnemonic, NBC, right? NSAIDs, B for or beta-lactam antibiotics, and C for cephalosporins, and they are basically bacterial cell wall inhibitors. And then if the patient again started on an antibiotic, suppose for endocarditis, and now has muddy brown granular class, then the diagnosis would be acute tubular necrosis and the drug is aminoglycosides. Okay, so moving on. Now we have some other drugs in this particular class, antimicrobials, and they are used for different situations. So let's go through them one by one. So first off, we have the piperacillin and the ticarcillin, right? So suppose you want a hard-hitting beta-lactam that you want to cover the gram-positives, but in this situation, the patient along with the gram-positives, he's a hospitalized patient, has sepsis, and you want to cover Pseudomonas as well, right? Pseudomonas comes back positive as well. So what is the antibiotic are you going to give? So the options are vancomycin, and the options are ampicillin, neficillin, and dicloxacillin, along with piperacillin, ticarcillin. So you are basically going to use piperacillin, ticarcillin because they have very good anti-pseudomonal coverage, right? Okay, then we have like the tazobactam or clavulanate. They are basically beta-lactamase inhibitors, and tazobactam or clavulanate can also be added to piperacillin and ticarcillin, right? Okay, so suppose, here's our Vinay. There's 30 male who has hospital-acquired pneumonia. How do we treat him? We are going to give piptazo, which is piperacillin, along with tazobactam. So piperacillin, our anti-pseudomol, tazobactam, our beta-lactamase inhibitor, along with Vanco, right? So why? You need to know all the three reasons. Piperacillin for Pseudomonas coverage. Tazobactam in order to prevent the degradation of piperacillin by beta-lactamase, right? So it's a beta-lactamase inhibitor. Vancomycin for the coverage of MRSA, right? So just remember this three like big gun combination: piperacillin, tazobactam, and vancomycin whenever you are thinking about a hospital-acquired pneumonia where their Pseudomonas might be a causative agent. Okay, next off we have the Carbapenems. So how are we going to memorize the Carbapenems? By the mnemonic DIME. D is for Doripenem, I is for Imipenem, M is for Meropenem, and E is for Ertapenem, right? And then suppose they give you a patient again, he has sepsis, hospital-acquired infection, and he has been given this hard-hitting Imipenem, right? But the Imipenem has been started with Celastin, right? And they ask you that why are we using this combination Imipenem with Celastin? So the answer would be that Celastin basically decreases renal clearance of imipenem, and it maintains the serum levels of imipenem so it can act effectively, right? And then if they ask you about the mechanism of action of imipenem or doripenem or ertapenem or meropenem, that would be they are similar in structure to beta-lactams, but the only exception is that they have a sulfur atom in position 1. That sulfur atom in position 1 in the beta-lactams is replaced by a carbon atom and an unsaturation has been introduced. This is not extremely highly, but yeah, just good to know that sulfur to carbon, so S has been replaced with C, and now instead of S, since there is a C, there is unsaturation, right? And of course the mechanism of action will be same. They bind to the penicillin binding proteins, transpeptidases, inhibit the cell wall synthesis, and then they inhibit the transpeptidase mediated cross-linking of peptidoglycan. We already discussed these 3-4 points in detail in our first video, so if you want to know more or you're confused about these, go watch the first video. Okay, so when do we use carbapenems? Again, I told you there are big guns, so they can be used for multi-drug resistant infections, and if the antibiotics are given for pancreatitis, yeah, this is one specific situation. For pancreatitis, the patient is extremely ill, so the antibiotic that you might consider are carbapenems, right? The DIME antibiotics, the Dori, Imi, Erta, and the Meropenem, right? And of course, like they cover Pseudomonas as well, just like our piperacillin, ticarcillin, but from amongst these, one has weak anti-pseudomonal coverage, and that is ertapenem. And an important important side effect. So suppose they give you a Vinay in which a patient has been started on a hard-hitting antibiotic. Patient is in sepsis, he's in a hospital, right? And he has a hospital-acquired infection, and the patient start developing seizures, right? So I remember this, that whenever you toss a dime or a coin in the air, it starts to have seizures and it starts to like shake here and there. So this means that seizures is a notable side effect of which antibiotic? The DIME antibiotics, right? So D is for Dori, I is for Imi, M is for Meropenem, and E is for ertapenem, right? So they basically cause seizures. Okay. Next off, so don't confuse, one very important thing, don't confuse the carbapenems to aztreonam, right? Because I used to confuse this a lot, and I would think that, yeah, aztreonam is also a carbapenem. No, aztreonam is not a part of the DIME mnemonic, right? So since it's not part of the DIME, aztreonam is another antibiotic. Got it? Okay, so it's a monobactam antibiotic. It also disrupts the cell wall synthesis. The only special thing about it is that it binds to a special PBP. It binds to PBP3, right? So again, it's a hard-hitting antibiotic, so it has to have something special, and that something special is that it binds to PBP3, right? And when is aztreonam a safe choice? It can be used safely in patients who have beta-lactam allergy. So suppose they give you a Vinay, the patient has beta-lactam allergy. Correct answer, aztreonam, right? And if they give you, we need gram-negative coverage by some sort of penicillin that we have to use because for some reason the patient is allergic to all the other antibiotics, so we need gram-negative coverage by just the penicillins. So for that you can safely use aztreonam. Okay, next off we have another big gun, which is vancomycin, right? And vancomycin is again, since it's like an advanced form of penicillin, so it will still disrupt the cell wall synthesis, but the only difference is that it doesn't bind to the transpeptidases or penicillin binding proteins, right? Remember, we discussed this in the first video, that the main penicillins that we have, penicillin, ampicillin, amoxicillin, dicloxacillin, cloxacillin, oxacillin, nefacillin, all these methicillin class as well, they basically bind to this, like the machinery that binds the two DLA together, which is basically the transpeptidases or the penicillin binding proteins, right? So this is the machinery or the construction construction workers which are basically responsible for bringing the building blocks together, and our penicillins were basically responsible for inhibiting this, right? So the vancomycin is basically more intelligent. It says, oh, why should I go and block these construction workers, right? Why should I not go and destroy the building blocks, right? Let me destroy the building blocks. No building blocks, no construction, right? So it directly goes and binds to the D-ALA, right? And that is why we will see that the mechanism of resistance will also be related to something changing in the D-ALA. Okay, so remember this very crucial difference. Don't forget this in the examination, that penicillin's mechanism of action, or the site of action you can say, are the transpeptidases or the penicillin binding proteins, whereas for vanco the site of action is directly the building blocks, the D-ALA building blocks, right? They are still inhibiting the cell wall senses, just that the site of action is different. Vanco directly inhibiting the building blocks, penicillins, the other penicillins directly inhibiting the machinery or the construction workers, right? That is the transpeptidases or the PBP. Okay, so when are we going to use panko? What's the vignette going to be like? So the patient was like, has come to the hospital, he has a MRSA infection, like some sort of endocarditis, right? Or he has ampicillin resistant enterococcus infection, or the patient has meningitis, for which you can use cephalosporin, ceftriaxone along with vanco, or the patient has endocarditis, where we have already discovered that the patient, you are going to use gentamicin along with vanco, right? So one is vanco notably not effective in treatment of MRSA infection. So the patient still has MRSA, right? But you're not going to use vanco. What is that situation? That is specifically if the patient has a skin MRSA infection, right? So in case of a skin MRSA infection, you are not going to use vanco, and instead you're going to use CD light. So this is our mnemonic. I'm sorry about this. Where did our So I was sorry about this. So if the patient has a MRSA skin infection, then we are going to use the alternatives. We are not going to use vanco because vanco doesn't have good skin penetration. So we are going to use CD light, and the CD light is basically clindamycin, doxycycline, linzolate along with TMP-SMX. C for clinda, D for doxy, L for linzolate, T for TMP-SMX. And the mechanism of resistance to vanco, remember this that I just told you in this diagram. The site of action is D-ALA. Let's change something in D-ALA, so vanco can't even bind, right? So let's convert this D-ALA into D-ALA-D-LAC in the cell wall. Okay, so let's convert it this second ALA into D-LAC. So once it is D-LAC, vanco, you can't bind over here. Okay, so ALA is for alanine and LAC is for lactate. Okay, and the toxicity of vanco we are going to memorize with the mnemonic not red. N is for nephrotoxicity, O is for ototoxicity, T is for thrombophlebitis, red is for red man syndrome, which is basically histamine induced flushing. So they can basically give you a vignette in which there was a patient and he was being treated for endocarditis, and now the patient is becoming red all over. He is basically having all this like this allergy sort of a reaction in which he is having like facial flushing and the body flushing, right? So they can ask you what is the mechanism, how did this happen? So that would be a histamine induced flushing or an IgE based reaction, or they can also say it was mast cell activation, right? And the diagnosis is Redman syndrome. And if they ask you about the causative agent, like what classically causes this person to become red, flushed over after an antibiotic is started, then the drug of course is going to be vanco. And if they ask you about its mechanism of action, that would be binding to D-ALA and inhibiting cell wall senses. And if they ask you of course like how could this be prevented, how could you decrease the risk that the patient does not become this red man who is flushing all over, so the answer would be that you could either give an antihistamine, which would be diphenhydramine. So then one option could be use of diphenhydramine, or another option, or in the same option could be the slower infusion of this antibiotic, which is vanco, right? So this concludes our part 2 of rapid fire antimicrobials review for USMLE steps. If you like this video, please like, share, subscribe and follow for more. And if you have any feedback of what you liked about this video, what you would like to improve, or there are any more topics which you would like me to make videos on, please put those in your comments and I will make sure to read them and respond to them and make those videos of those topics that you have suggested. Until that time, I'll meet you in the next video. Until that time, happy studying.